Okay, let's get started with this final day of the conference. We had 2 great days on Monday and Wednesday of this week. First, addressing understanding your audience and their needs, followed by a day focusing on environments, formats, and strategies. On Wednesday, we heard from Dr. Melanie Barwick about using the KT planning template, or KTPT, to develop a thorough KT plan. A KTDRR activity involving working with Dr. Barwick to see how NIDLR grantees can best make use of the KTPT is in the works, so please watch for follow-up information on that. Jennifer Flagg followed with a discussion and description of the technology transfer planning template that's modeled on the KTPT. The last session of the day was from the NIDLR-funded Model Systems KT Center, or MSKTC, that works with grantees focusing on traumatic brain injury, spinal cord injury, and burn injury. Deeza May Smith, Tiffany Brewer, and Amber Hammond shared information about social media efforts and tools. Allison Todd from the Rehab Institute of Chicago shared information about their use of the MSKTC's tools. We then had a spirited discussion led by Jennifer Moore of RIC and Jessica Chaikin of NARIC. Now let's talk about what's coming up today, where we focus on policy and outcomes. Our first presenter will be Catherine Oliver, and she'll discuss her research related to barriers to and facilitators of the use of evidence by policymakers. After a short break, we'll hear from Joe Lane of the Center on KT for TT with his presentation on linguistic and conceptual barriers that hamper effective communication with policymakers and implementers. After another break, we'll end the day with an interactive discussion session and conference synthesis. First, we'll hear from Catherine Oliver, PhD, who is a departmental lecturer in the Department of Social Policy and Intervention at the University of Oxford. Her PhD from Manchester in 2012 was half sociology, half public health, exploring social networks of power, influence, and evidence use in public health policymaking. Dr. Oliver is Associate Editor of Evidence and Policy Journal, an expert advisor for the World Health Organization, and a member of SOCMED and INSA, and a regular contributor to Research Fortnight and other media. Catherine, if you're ready to go, please take it away.
Great. Thank you very much, and thank you to everybody for coming along today. What I'm going to talk to you about is some work which I did associated with my PhD and some of the thinking that I've developed about that over the last 3 years. So if you want to follow me on Twitter, I do often tweet about evidence and policy issues. You can see my Twitter handle right there. Okie dokie. So when I first started my PhD, which was back in 2009, I did a literature review about evidence-based policy research, and what I found was that many of the studies which I was finding were really based on very simple models of evidence and policy, and much of the research in that literature review explicitly aims to try and increase the amount of research used in policymaking, or explicitly aim to upskill policymakers, so to try and help policymakers understand how to use research in a more effective way, or very occasionally to present joint narratives of how evidence was used in what people would tend to call the black box of policymaking. Now, this is one model here on the left-hand side, and this is actually from Andy Oxman's work from 2009 that I'm sure many of you are very familiar with. And this is one of about 90 more different models of the evidence and policy cycle that we found. And really, I could have chosen any of them, and they have a lot in common. And what you can see is that at the top, people are identifying problems, identifying options to try and address those problems, implementing them, evaluating them. And I think the general idea behind these models is that we go round and round and round, and policy gets better. Now, my experience from having been involved in policymaking processes, it doesn't usually look like this. So I became a little suspicious. And what I became to realize was that these models, while kind of helpful for helping us to think about how policy might work, actually aren't verified on independent empirical data sets. So they're not validated on, for example, ethnographic accounts of policymaking. and to some extent they can be quite unhelpful because they give us this false picture of what policymaking processes are really like. And what I really came to struggle with was if we don't understand the policy process as academics who are hoping to influence it, how can we possibly hope to try and change things? So this is what my PhD ended up being about. And I realized that there's a number of questions that I really needed urgently to find answers to before I was going to start running around telling policymakers how to do their jobs better and how to use evidence more effectively. I wanted to know what evidence policymakers really needed or preferred. I needed to know where they got it from, how they used it, and unpacking that concept of use is a whole PhD in itself. And in fact, even who the policymakers really were. And what it seemed to me was that behind this cycle that we all talk about so frequently, there's a really huge missing part of the picture, and that's the human factor. So it's human beings making these decisions, how are they connected to one another? And this is what I ended up studying. So the very first step was to do a systematic review of barriers and facilitators of the use of evidence. I'm sure many of you are familiar with Simon Inver's review, which was published in 2002, where he looked at the barriers and facilitators of, as reported by health policymakers, perceptions about evidence use. So I got in touch with him, and together we updated it and broadened it out to look at all policy areas, so not just health, and look at all types of studies, so not just people's perceptions, but also interventions, if available, ethnographic studies, and so on. And originally he had I think something about 22 studies, and we found 145 studies to include from over 59 countries, and of which 13 were systematic reviews. So really a huge increase in the amount of research that's been done in the last 15 years. And looking at these 145 studies made me kind of grumpy because so many of them were the same and came up with very normative descriptions of the policy process. So if anybody's interested, you can read my quite ranty essay that I wrote afterwards about what we needed to, what were the next steps for research in this area, and that's something I'm going to go on to talk about later on. Okay, so what did we find? Of these 145 studies, we found that most of them were still in health, so a good 126 out of the 145 were about health-related policy. They included public health, secondary and tertiary care, primary care, health policy, and so on and so forth. But there were a significant number of other policy areas as well, so going all the way from transport to education, including food policy, even if you're in criminal justice, even economics. So a much broader range than had been found previously, obviously reflecting our broader inclusion criteria. And generally these questions were, these studies were mainly surveys asking both academics and policymakers about their perceptions, attitudes, and opinions. So predominantly survey and questionnaire studies asking explicitly what helps you to use evidence, what stops you using evidence. Very few studies really looked at processes of research use, research uptake studies, or interventions. So there wasn't much empirical data about the way evidence and policy kind of interacted in the field. It was mainly to do with people's perceptions. And I think only about 6 studies where they actually evaluated the use of research in any way. So we coded these 145 studies and had a look at what the top barriers were and the top facilitators. And, fairly predictably, they were very similar to what Simon had found in his original review. So the main barriers were said to be lack of availability of access to research. Maybe the research was not very clear. It wasn't relevant to what policymakers wanted. It wasn't very reliable. Or they were more sort of resource-oriented barriers around having no opportunity or no timing. And again, the low policymaker research skills came up as a large theme. And conversely, the facilitators were reported to be, if you did have good access and dissemination of research, that was a useful thing. Collaboration and good quality relationships between researchers and policymakers were the other main facilitators. Now we break these down into different themes, so 5 different themes, because we had overall, I think, about 112 different factors which were reported to influence evidence use. So around contact and collaboration, that was our major theme. So most studies reported at least one factor in this theme of contact and collaboration. And it really seemed that people were talking about the importance of having good quality relationships between policymakers and researchers was a key factor in promoting evidence use. And that was, it was partly to do with trust and having somebody on the end of the phone, but it was also to do with the kind of research that was done. So if you had a good quality relationship with a policymaker, they would probably commission you to do research that was then useful to them, which obviously they would then be more likely to use. So the next theme was about organizations and resources, and this was quite pragmatic kind of stuff to do with things like having the support of managers and personnel, and both in academic and in policy contexts, it was recognized that cost and staff turnover were huge factors affecting both the production of research and its use. And a lot of this was to do with aspects of, for example, institutional memory. So if someone's only on a 2-year contract, it's very difficult for them to maintain a relationship with a policymaker once they've left their own university. Lots of factors associated with research and researchers themselves. So again, the clarity, relevance, reliability of research was held to be important. And this is a lot about the credibility of the research that's presented to policymakers, but also about the importance of the research that's done. So as academics, we all love to believe that our research is of the most paramount importance. And one of the factors that was reported was that policymakers don't always agree that our research is the most important thing. And that's something that some of the academics in our studies were struggling with. And policymakers themselves, they were reported to not really be very aware of research that was going on, maybe not have the skills to assess it or to use it appropriately to be able to judge what good quality research looked like. But there was also a recognition that the importance of political support was a key factor in promoting evidence use. So in countries where there is top-down governmental support for evidence use, that tended to promote research use through all levels of government and legislation, unsurprisingly. And we also had a theme about the policy itself. So this is kind of about the nuts and bolts of policymaking. So the recognizing the other pressures on policymakers, like democratic processes, like the media, like public opinion, and also sort of the ways in which government policy reaches practitioners, so through, for example, guidelines and policy statements. And also the urgency of the policy itself. So if there was a huge crisis to do with an epidemic or some kind of famine, for example, that was obviously a completely different need on the part of policymakers than for something, tinkering with a primary school education, teachers policy, for example. So again, the policy itself generated a number of factors. So as a Brit, it's compulsory that I have a picture of Benedict Cumberbatch in all of my presentations. And when I was, well, the reason I put him in there is because I think, and I felt at the time, that this made me very suspicious. I wasn't really convinced by this story that we, as academics, didn't understand policy, that policymakers didn't understand academics. And I thought it was interesting that the story really hadn't evolved in any way over the previous 15 years. And I wanted to do a bit of digging about that. So what can we learn from this literature? So when I was going through these 145 studies, I noticed 3 main assumptions that a lot of these studies were making over and over again and had been making consistently since before Simon published his research in 2002. And the first assumption was that there was a gap between evidence and policy which needed bridging, and it needed bridging by some kind of institution or some intervention. It also tended to assume that policymakers don't use evidence. They don't use evidence of any kind. And thirdly, we assumed that more use of academic research, because that's what people tended to mean, would lead to better policy, whatever that is. So here's another model of policymaking. And again, we can see here that the idea is that you put in the evidence and then at the end comes out policy outcome. And I just found myself wondering is the first assumption, the gap between evidence and policy. This really comes from some work that I'm sure you're all familiar with back from the 70s and 80s, when people like Carol Rice, and the people who started working on the two communities, Kaplan and so on. And it was originally a construct which was quite helpful to describe the different pressures on academics and policymakers and the reasons why there might be differences between the two groups of people. But I think really it's turned into kind of an unhelpful stereotype now. And when we talk about ivory towers academics and we talk about policymakers who are not able to engage, not able to understand what academics do. And I think this doesn't reflect the reality of either academics or policymakers. And there are a number of people who I have personal contact with who have hybrid roles. They have split careers between local government and local academic institutions. And of course, maybe there's also knowledge brokers and a number of funded interventions which are meant to bridge this gap. So I think maybe it would be more helpful to describe one another as colleagues rather than as being two entirely different species. The second assumption was that policymakers simply don't use evidence. Now, I did a study a few years ago, which was published this year, looking at how evidence is used in public health. And this was a survey of local government officials and politicians. And what it showed was that it was true that academic research was used. So you can see there's meta-analyses, experimental data, systematic reviews, and qualitative research studies were all reported to have been used. But much more widely was local data, and so joint needs assessments, practice guidelines from the government, and things like that. So policymakers undoubtedly do use research, perhaps just not always, they do use evidence, perhaps just not always academic research. And I think this really talks back to the question of what the role of academic evidence in policymaking should be, and perhaps our desire to have our research be more influential has kind of outweighed our interest in understanding what it is that policymakers do. And they have to balance a lot of different values, a lot of different sources of knowledge, a lot of different sources of evidence in making their decisions. And that's something that our research simply doesn't reflect at the moment. So when you look at where policymakers get their evidence from, this kind of also backs up the assumption, backs up my finding that they do continue to use evidence and knowledge of different kinds, just not always research evidence. So this shows the different types of people and different types of organizations where policymakers accessed their evidence from. And you can see that mainly they like to get it from other people, so mainly experts in the area. And when I went and interviewed them later, I asked them who they meant by experts, and they said, well, anyone who knows more about it than I do, which is kind of an interesting definition of expert, but quite a useful one. So experts could be someone in the other parts of the government. It could be someone who they just happen to have known for a long time, perhaps someone they were at school with, perhaps a local academic. But predominantly people were talking to their colleagues, to their local friends, and so on and so forth. So a lot of advice and expertise is used in policy making, but I don't think that means it's an unhelpful type of evidence. I think what this means is that we need to understand how policymakers access evidence and what kinds of information they need and find useful before we start to try and influence policy. Okay, so the third assumption was that more use of research would lead to better policy. I just thought I'd put that picture back because we all like a picture of Benedict Cumberbatch. And I have never yet seen a single study which showed me that having used evidence made a substantial improvement to populations. I think it's extremely difficult to evaluate that. And I think there's a number of ethical problems associated with saying that that kind of technocratic process is the best one. I think there's lots of different ways to make policy, and I think we need to be very careful about saying that more use of research would lead to better evidence. I think what we do need to do is say that more understanding of how evidence can contribute can help us to develop better policy. But before we know what better policy is, it's kind of difficult to go down that route. So when I wrote my essay afterwards, after having reviewed these 145 studies, we wrote this, we came up with these 6 new directions for evidence-based policy research. So new research questions that we thought had really not been answered by any of these studies in our review. And these are around, okay, so yes, we do know lots about the factors that people say influence evidence into policy, but we don't know very much about what influences policy itself. So just looking at the evidence part of the policy process seems kind of unhelpful. Maybe we should try and look at the whole process and do some more ethnographies of that. We need to understand what policymakers actually do use and how they find it, as I said. And understanding what we mean by research impact, influence, what different contributions of research could make to policymaking, and trying to unpack that a little bit. So maybe, a randomized control trial can be extremely useful in some settings, but obviously in other settings, something like a media story is going to outweigh any evidence possible. And trying to understand how those different types of knowledge interplay with one another, I think might be quite a useful thing to do. We need to develop more appropriate methods to evaluate the processes and the impact of evidence use and implementation, because at the moment, as I said, we really don't understand how evidence is used in policy or for what purpose. And we need to understand the role of the organisations, networks and individuals, so the human factor behind policymaking. And finally, for those who are interested in influencing policy, I think clearly indicated by the Barriers and Facilitators work is a need to identify ways to promote collaboration and co-production, as they seem to be the main factors which people thought promoted use of evidence. So I'm just going to talk about the latter two and show you a few of my slides from my PhD work. So I did a network study looking at who influenced public health. So this is where I asked members of the public health policymaking community to nominate one another to say who they found were the most influential people and who they went to for advice. And so I've color-coded it by the kind of organisation that they work for. And NHS is our National Health Service, so these are health policymakers. Local government are in blue. And then there are university people in there, but unfortunately they're very small, and they tended to have nominate only really one another, which is kind of a bit depressing. But what you can see is that the main policy, the most influential people, those are the biggest blobs there. There's one from the NHS, most of the local public health, the person who's accountable for public health spending, so that makes sense. And the other people are actually kind of a bit tangential. There's one from the council, there's one from the NHS, sort of another NHS manager. And when I went and interviewed people about why these people were the most influential, they basically told me lots of stories about how policy really works. And I wrote this up as a kind of framework to try and understand the policy process. So I'm still working on this, and I'm not entirely convinced that this works, but I thought I'd just talk you through it and see if you had any interesting feedback for me. So when I asked people, how do you go about influencing policy, they came up with these 4 main themes. Controlling policy organizations, which was really about being able to create and manage key organizations in the process. Controlling the actual content of the policy, and that really was as detailed as deciding the topic and the actual specifics of the policy which they intended to implement. Controlling policymakers directly, and that was about managing other people really. And then finally using network structures, so being able to identify and maintain key relationships which they needed to have in order to progress the policy. So the first one of these, controlling policy organizations, I'd like to give you an example which is to do with minimum unit price for alcohol. So in the UK we've been batting around for a couple of years now, some ideas about different types of pricing structures for a tax on alcohol in an attempt to reduce drinking. We don't have any empirical data that it will work, but there are some models which suggest that if you do have a minimum price, so you raise the cheapest alcohol in price, that it should reduce harmful drinking. And the way this worked in my sample was that there was an organisation which was called the Health Commission, and its job was to report to the local government on certain key areas. So these were obesity, tobacco, alcohol, all the usual public health areas. So they knew that at some point someone was going to ask this commission what they had done on alcohol, and the time drew near for them to prove that they had been taking action. And what they did was they sat in a room, 3 of them. So Alistair was one of the main larger blobs from the previous slide. They sat in a room, 3 of them together, 3 council officers, and Googled alcohol. And they found a report from the Chief Medical Officer in Scotland which mentioned minimum unit price for alcohol. They thought, this could work. We could raise this at our next council meeting. Alistair, who was our key figure, he managed the papers for that meeting, so he wrote the agenda and the work programme. He sounded out a few people before the meeting and let them know that was what he was planning to do. So they had this idea for controlling policy, for minimum unit price. They identified it as a possible policy. The next thing to do was to develop the policy content. So what they did was they found who the academic was who had been working on it. It turned out that she worked in a nearby city and she could come over very easily. She'd also been on the TV and on the radio, so she had a reasonable amount of credibility, and they thought she would be able to speak well to the local politicians. So they identified some experts, they attached her to the policy, and they drew up the policy papers explaining exactly how this tax was going to work across the different parts of the borough. The next thing to do was to control the policymakers directly. So they identified the local kind of tame executives. So this is people who are running local council, running local health organisations, to present the policy and to champion it around the system. So they persuaded local and regional politicians to endorse the policy, to say publicly in different fora that they thought it was a good idea and this was the way to tackle harmful drinking. And when I asked them, okay, so this was a couple of years ago now, how do you think it's going? Do you think drinking has changed since this policy? They said, oh, well, it was never implemented, but it was very successful. So I said, okay, that's interesting. Why was it so successful? And they thought it had been a brilliant success because even though they were only a small city in the north of England, they had managed to get national media to pay attention to them. And they had managed to get the Prime Minister to pay attention to them as a city. And it made them look much more visible. It made them look very credible as a policy-making legislature. So they had a much stronger bargaining position with the national government. So in the end, it turned out it didn't have anything to do with harmful drinking or alcohol at all. It was to do with a much wider set of priorities around devolvement from the national to the local government system, and they knew that they were going to be facing monetary cuts and so on. So they were very pleased with the way it worked out. And I think in terms of our discussion about barriers and facilitators, I think what this shows is if an academic had turned up and said, well, I think you should use my trial, which shows that harmful drinking is affected by this intervention, that intervention, it's almost completely irrelevant because the outcome that they are thinking of is not to do with population health at all. It's to do with the political process. So while it may have been used, and it's possible that it could have been, you would have had to have understood all of this and understood the mechanism which linked this hugely intricate political system together in order to be able to influence it and try and tweak it and push it into a place where you would get your outcome, which would be a bonus for them. So what I concluded was that it's really important to know, okay, who is influencing this policy and what is their actual end game, and where do they find their information? So in terms of the facilitators of evidence use, that makes sense. We're talking about context and collaboration. So if they had managed to identify a local academic who did work on alcohol, if that academic had been on the end of the phone, rather than them Googling and finding a random report, maybe there would have been a different debate. Maybe there would have been much more effective, much more useful local data which they could have designed an intervention around. But they didn't have that relationship, so they had to go by what they'd found in a kind of completely happenstance way. So it's very important to try and create these relationships between influential people and reliable evidence producers. And for any kind of relationship building, that takes time and obviously takes several years usually to build up the kind of relationship where you would feel able to simply tap someone on the shoulder and ask them for their advice. And of course, the thing about academics and policymakers is that while they're often the same people, they do have incredibly different career pathways. So as academics, we're judged by our outputs, by our papers and citations, possibly even teaching. We're dependent on and accountable to our grant funders, and we need to demonstrate independence and rigor, and that is what we're valued for by policymakers. Policymakers, on the other hand, are judged by entirely different metrics, and that really differs depending on where they are in the system. Politicians are, we decide what we think of politicians, and for any number of reasons. Policy officers, who are the ones I was talking to, were probably mainly valued because they prevented political disaster, rather than for any other reason. But they do have a need to demonstrate that they have considered other legitimate sources of evidence. So they need to demonstrate that they're being accountable to the public and to taxpayers. And that's something that I think adds a really interesting dimension to the whole debate about use of evidence. So in conclusion, I think the conclusion I came to was that policy can really be influenced by almost anybody. It can be influenced by policymakers, by officials, by experts, by the public. It depends very much on context and on the area. And understanding how to mobilize the hugely complex machinery of policy is really dependent on the ability to understand those influences and understand the relationships between different people involved. And I would go so far as to say, know how to exploit them. So one of the characteristics of the people in the middle of the network, the really big nodes, people like Alistair, who is central to the minimum unit price policy development that I spoke about earlier, he was able to identify, look around the system and identify who was going to be his ally, who would not be his ally, and who he needed to sort of neutralize in some way. People who he didn't yet have relationships with, but he thought he should have relationships with, and then he could quite happily go out and create them and maintain them. And that's a real skill that we are not taught as academics at all. And I think rather than trying to be able to do that ourselves, which would obviously take a huge amount of time, I think the best thing, one of the best things that we might be able to do as academics would be to harness the skills of those individuals. So to work out who they are, talk to them regularly, build up a relationship with them, and then hopefully they will post our knowledge around the system as and when. So essentially we need to take the interpersonal seriously. The human factor is what underpins both the production and use of evidence and the whole policy-making process. Thank you very much.
Well, thank you, Catherine. That was very interesting. You got some really pertinent information, I think, for all of our listeners here. And I've got some questions that people had sent in to us, and they may not necessarily be focused on your presentation because these were sent in during registration, but I'd still like to ask a couple and just see what your thoughts are from the wealth of experience that you have in this area.
That sounds fine.
One of the participants said that they were really interested in knowing what are the kinds of things that really bog down or prevent good discussions with policymakers? I wonder if you have comment on that.
What are the things that just sort of make conversations with policymakers difficult?
Exactly.
Well, I mean, in my experience, it depends. It depends. Classic academic answer. I suppose I'd say it depends very much on the policymaker. So, if I go in and talk to someone, whoever it is, whether that's a funder, a journalist, a policymaker, how they perceive me is entirely down to their perception, their sort of inherent prejudices and that kind of thing, and what they want to get out of me. So if you're pushing on an open door because they've indicated that they would like your advice, then obviously life is going to be much easier than if you're trying to convince someone who automatically disagrees with you. But the main things that I think you can do to make your life easier for yourself is demonstrating that you understand what it is that they need from you, what pressures they're under. So, do you know what the policy agenda is in that area? Do you know what decisions they're going to have to be taking around budgets? If you can demonstrate that you kind of get where they're coming from, I think they're much more likely to feel that they can trust your advice, is what I'd say.
Okay, we have another question.
Sure.
Can you identify some strategies that work for researchers to build relationships with policymakers? By that we mean, what are some good ways for researchers to be able to understand better the world of the policymakers?
Well, I think there's a lot of things that we can do that are relatively easy and not that time-consuming. So when I was doing this work in Manchester, I went to all of the public meetings where these things were openly debated and voted on, and I was, without exception, the only academic there. And there are 6 universities in that city. So I think sometimes just going and exposing yourself to the policymaking process in whatever way you can, I think is really helpful. Getting to know people and going and talking to, the key, the people who run the meeting, to the people who write the agendas and so forth. I think that can be really useful in initiating conversation. And sometimes all you need to do is get your foot in the door, and then you become the public health person that they call. There have been a number of sort of funded initiatives around, like knowledge mobilization. I think they're called knowledge brokers usually in North America, where academics are funded to go and hang out in policy organizations. And I think one of the pros to that is that obviously you don't have time to get to know the policymaking process properly. I think one of the downsides is that you end up, as the academic, you end up becoming a bit of a generalist and becoming the go-to person for everyone. So my personal preference is to try and get to know the movers and shakers and to target them. And when I say target them, what I mean is just being on their radar and coming across as a professional and credible person as much as possible. And if they ask me for some advice, I send them 100 words rather than a 3-page or even, heaven forfend, 200-page report. So, you're very lucky if you get more than 30 seconds with a policymaker. Sometimes it's all about just trying to make their lives easy for them, really.
Okay, thank you very much. Let's see if we have another question here. Here's a question. This is related a little bit to yesterday's discussion. How do you see the concept of integrated KT, where policymakers are part of a research project?
So I'm working on a project, and it's like that at the moment. We're working very closely with local government officials and managers. And what they're doing is they're telling us which areas in which they need to cut funding. And then we, as the academics, are coming up with different ways to design services. So that works really well because they're kind of setting the research agenda for us, but they're not setting the research design. So we're still able to maintain control of the academic rigor and the evaluation strategy. They're kind of just giving us different areas. But I'd say something in the region of 5 years went into building those relationships before we got to that point. So I think it can be a really valuable thing to do, to work that closely with policymakers. And in fact, I think it's probably the only way in which academics are really ever going to be able to deliver research that's directly relevant in a really timely way. One of the really useful things about it is that they've been able to tell us what they're going to need next year and the year after. So we're able to start working on things in time for them to be able to deliver, for us to be able to deliver in a useful way. So that's been very helpful. But I think it's very important to be mindful and thoughtful about the different ways in which academic independence can be compromised. So we've had to do quite a lot of thinking about who owns the data and who's involved in designing and disseminating different bits of research. Do they get to look at our findings before we publish them and that kind of thing? So I think it can work. I just think it needs a lot of thought, and it's much better done thoroughly than done in a take-holistic manner, but that's probably obvious to say.
Thank you. This one is a little bit of a different twist. Can you give some comments on how to implement knowledge translation from research to practice within a health institute and in the future to policymakers?
So how to implement within healthcare?
Right. That must be the perspective of our questionnaire.
Okay. So in healthcare in the UK, a lot of what practitioners actually do is controlled. They're advised very directly by guideline development, which is very different from policy, where they have a much freer hand, and by local protocols and audits and that kind of thing. So I don't know, it's probably different in different countries. But if you're trying to implement something, a new intervention in, for example, primary care in the UK, you have to, again, know exactly who to get on board. And in that case, it would be the lead partner of a GP practice and probably the local improvement nurse. So building relationships with them before doing any cold calling or turning up and saying this is how you're doing your job wrong is obviously going to be much more effective. I think in terms of policy making, I think there's an interesting distinction between the level of evidence that's kind of accepted in policy and in healthcare. And most clinicians these days are very familiar with the concept of evidence-based medicine, and they know about the hierarchy of evidence and the systematic review, meta-analysis, RCTs being the most reliable, and so on and so forth, in a way that policymakers generally aren't. So in some ways they might be more receptive to improvement, but fundamentally they're going to be dictated. The other pressures on practitioners are financial and the care of their patients. So, again, like policymakers, they have to take a lot of other things into account, and the more that we can demonstrate that that's the case, the more that we understand that that's the case, the more our negative stereotypes about academics will be eroded. I hope that's helpful.
Great. That was very helpful. Thank you. See, we have a comment from one of our participants.
Mm-hmm.
In her experience in producing health technology assessments, often commissioned by policymakers, there's the potential for policymakers to unduly influence the design of studies. But this is highly encouraged and expected as they are funding the evidence synthesis. In one sense, this is a partnership with a stakeholder, but it's hard to know where boundaries should be set. What are your thoughts about this?
Yeah, that's a familiar struggle, isn't it? It can be really difficult because obviously you don't want to jeopardize relationships with funders in the future. In my own experience, the way we've tried to handle that is from the very beginning of the relationship being really clear about expectations. And in a way we've been a little bit Machiavellian about it and just tried to say what's really valuable about having policymakers around the table is that you're so intelligent and useful and experienced in how decisions are made, and we just do the boring evaluation stuff that you don't want to get involved with. you just really want to tell us your expertise. So, I think there's different ways of handling it, and some people are much more, a lot of people are much more tactful about it than I am. The difficulty comes when the money comes with strings. So we've had that a couple of times. I've had that a couple of times where people have said that they want to see the final the manuscript that I want to publish before I send it to the publisher. And those times I've said no because I've blamed it on my university ethics approval and said that I wouldn't be able to get it through ethics if we did that. So that's been a tactic that I've used. But I think in general, people understand the need for rigor. And I think if you simply explain in very simple terms the ways in which the credibility of the research can be called into question by having involvement in places where it's perhaps less appropriate, I think people usually respond quite well to that. Not always, but that's generally been my experience. The other main problem I've had in involving policymakers in my work is when the research hasn't gone very well, and when we haven't had any, like for example, we've done a survey, haven't had any haven't had any responses, or just really struggled to recruit, and they sort of, when people commission research for political purposes, they want to prove that what they're doing is really effective or whatever. I think the strategy I now take is to put in a contract with them, is now to say, we have to be prepared for the fact that this intervention might show no effect. And then it sort of tries to, diffuse problems down the line. So that's been a real learning experience for me.
Well, thank you very much. We have another question. If there is a written agreement governing the partnership, this issue can be stipulated prior to the work. I guess it's really a comment on what was just recently said.
Yeah, that's absolutely right. And I think one thing that universities are increasingly good at is helping researchers to negotiate these relationships. So I'm at Oxford now. I was at UCL last year, and both of those universities have a unit they usually call something like public policy or public outreach, and they're sort of lawyers and PR experts really who can help you to negotiate some of these quite difficult conversations and help you draft difficult emails and help you to do the write the proper legal contracts to sort of protect you. And then your job is just to try and get along with people, which kind of makes life much easier.
Okay, we have another question from Kathleen Murphy. How does work to impact policy differ from lobbying activities?
And that's a great question. And I think it's something that public health particularly really struggling with at the moment in the UK. I think my own feeling about it now is that I think it's maybe an age thing. The older I get, the less confident I am that I'm an expert in anything. But it's also, I just feel personally uncomfortable about going beyond the evidence that I am, have personally generated and analysed. So I feel able to talk about what I know, but standing up and being a representative of, for example, public health makes me very uncomfortable. But other people feel differently, and they feel that if they do have the ear of the politician, then it's kind of their duty to stand up and be a professional representative. So I think lobbying can be, lobbying is very different in the US than it is in the UK anyway. I'm not really familiar with other country contexts, I'm sorry about that. But I think we can learn a lot from how lobbyists do negotiate the relationships and do manage to create those networks and work out who to talk to. I think, unfortunately, we're never going to have as much money as them, so we're just going to have to be a lot nicer while being mindful in a way that they don't have to be, as the ethical constraints and the validity issues around our message.
Thank you. I've got another question that came in during registration that is a little bit different focus. It's more what you had recently said, talking about academia. How to catalyze the change in an academic environment that will increase the recognize the value of knowledge translation. So we're looking more at PhD here than policy, but it is the value within academia.
So sorry to harp on about the UK context, but I think that it's interesting to think about. So in the last year, we had the Research Excellence Framework exercise. For those of you who don't know, that's a kind of a performance management exercise for universities, and every academic and every department has to put forward all of the best research that they've had. And previously, it's just been papers. And last year, for the first time, people had to submit these things called impact cases, where they had to write down a description of how a piece of research which they had done in the previous 10 years had had some impact. And it could be impact on policy, on practice, on populations. That was really left open because it was such a kind of new initiative. And what that's done is it's really made people think about how what they do affects the outside world, and also how we can evaluate it. Because obviously, evaluating that kind of impact is incredibly difficult because it happens after the funding has finished, so you don't have any time to go and find out about it. But this time round, so in 2020, I can't remember, we're getting 25% of all the funding that's given out by the UK government is going to be determined by those impact case studies. So it's going to be a much bigger deal, and people who are going to have demonstrable skills in knowledge translation are going to be in a very strong position to argue for that. Increasingly, it is recognised in career progression in the UK, but it's still kind of a minority interest. But I suspect that funders will want to know increasingly what effect their research is having. So universities will be kind of forced over the next few years to kind of take this stuff into account a bit more. I hope, anyway.
Thank you. Does the impact case studies that you're talking about, that really sounds like an excellent program, and I'm glad to see that you're having some good results. We often look at what's going on in Canada and the UK and other places to see how we can make some changes here. So we really appreciate getting that different perspective that you have coming from the UK.
Sure. Well, sorry.
I was just going to say we have another question that's coming in, but go ahead and make your comment first.
Well, what I was going to say was that at the moment I've got some money to analyse the impact case studies. So over the next year or so, I'll be publishing papers on what the impact cases look like, what kinds of impact people are having. I'm happy to direct people to those. Also, for those in a health context, if you look at Tricia Greenhalgh's recent publications, I think this is in BMC, one of the BMC journals, she just published an analysis of all of the health impact cases. So that'd be a really good place for people to look if they're interested in that.
Well, thank you. We'll definitely be following up on those. We do have another question from Andrea. Mm-hmm. Do you think it's a good idea for a researcher to try to build relationships with policy officials or technocrats first rather than the actual policymaker? A policymaker and a policy official may be quite different in nature, although you may find them residing in the same building.
Yes, I think this is a really interesting question, and one of the things that I realised I still didn't know at the end of my PhD was who policymakers were, or what policy was actually. But one of the findings that I had was that it wasn't really about people's roles. So we had 10 directors of public health who were all basically council officials, so local government officials by the time we finished. And really only one of them was regarded as being influential. And it wasn't because he was a director of public health. It was because people liked him, and he was perceived as being friendly and useful, and would go out of his way to help you and basically seem like a good chap. Whereas some of the others were seen as being a bit argumentative, or just too busy to turn up and that kind of thing. So yes, I do think that going going to different parts of the policy system is a good idea, but I think it's an even better idea to know who's likely to listen to you. So sometimes that will be the politician, sometimes that will be the policymaker.
Thank you. We're getting close to the end of our time here, and I really do appreciate your being able to field all these questions from different areas. I have another one here. Isn't advocacy work for community organizations but not for researchers?
Yeah, I think a lot of people do hold that view. My own personal take on that would be, what do we mean by advocacy? So if I've done a randomized controlled trial on something that's extremely pertinent to primary care and it really saves a lot of money and it really helps the patients, I would feel it was my job to tell people about that. And what I mean by that is identifying who the market is. So the analogy I like to use thinking about this is about Apple. When Apple bring out a new iPhone, they know exactly how many, well, pretty well exactly, they know how many they're going to sell. They know how big the market is overall. They know what percentage of the market they're likely to get, and they've got really good strategies for maximizing their market share. And I think it would be really nice if researchers sometimes thought about that. I mean, obviously not quite as aggressively, but if I found out something that I think really works in this particular context, I think it would be a good thing if I knew exactly how many people this is relevant to, and I had an idea about how to reach them. I don't think that necessarily means that I don't have to advocate on behalf of all of public health and speak as an expert across all public health domains, but I do think that we have responsibility as publicly funded people to try and help the research that we generate to reach the right people. And, we can do that in an ethical and a thoughtful way without compromising ourselves. And a lot of the time, it's absolutely true that community organizations and charities and lobbyists have much better ways of doing this than we do. And I think, well, let's use them. Let's get in touch with them and use their networks.
Okay, let's try and squeeze in one more question along this line. The issue of advocacy, though, comes in framing research questions and agenda, and that's way before the compelling findings.
So the advocate would be the people then sort of deciding what research gets done.
Right.
I suppose it's possible that happens. I mean, in a way, this relates back to the question about involving policymakers as the process. I think, again, you can get a lot of support within universities these days to help you navigate some of these issues. And a lot of discussions about this have been happening over the last 15 years, especially around sort of patient involvement. And I'm trying to understand who should generate research questions and who should be involved in different parts of research and how and why. And I think there's kind of two camps. And there's one that says patients are the people who understand their lives best and their conditions best. And there's the other camp that says, yes, but researchers are the ones who know where the research gaps and what the next research questions should be. And I think there is an intelligent middle path between those two. And the same applies to advocacy. Researchers, it's about recognizing what our own skills are and what the skills and expertise of other people are. What we're good at is identifying gaps in research and understanding how to address different research questions using our portfolio of research skills and research techniques. And what other people are good at is informing us about context, about other pressures, about feasibility, acceptability, and so on. And so sometimes I think we just need to be a bit thoughtful about it before we launch into wholehearted engagement.